All right, welcome. Today we're going to do something a little different. We're going to step into a high-stakes surgical oral exam. I'll be your candidate, and together we'll walk through a classic esophageal cancer case. You're going to see the questions, my thought process for the answers, and the kind of clinical reasoning that's needed to ace this. So take a deep breath, the exam is about to begin.
Okay, here we go. First question. A 62-year-old man, trouble swallowing. This is a textbook opener. Now, the examiner here isn't looking for some brilliant out-of-the-box diagnosis. What they're really testing for is safety. They want to see a methodical, structured approach because in a case like this, jumping to conclusions can be a fatal mistake. So we start from square one.
So my first move as the candidate is to start gathering clues. Before I'm even thinking about scans or scopes or anything like that, I need to build a rock-solid foundation with a really thorough history and a physical exam. This is where the detective work really starts. Okay, so I tell the examiner that I'm zoning in on a few key questions. I need to know exactly how this started. Did he first have trouble with a piece of steak and now even soup is getting stuck? That progression from solids to liquids screams of physical blockage, something growing, like a tumor. I'm also hunting for any alarm bells, unexplained weight loss, any signs of bleeding. And I'd make sure to ask about hoarseness. A change in his voice could mean the problem is advanced, maybe even involving the nerves to the vocal cords. Right, a very logical follow-up. The examiner is now checking if I can connect the dots from the history. They want a list of possibilities, the differential diagnosis, but it needs to be organized. You have to put the most dangerous, most likely thing right at the top. For a guy this age, with this story, esophageal cancer has to be #1 on my list. No question. I'm thinking about the two main types: adenocarcinoma, which is often tied to long-term acid reflux, or squamous cell carcinoma, which we see more with smoking and heavy drinking. But you can't get tunnel vision, so I'd also list other things we need to rule out. Benign causes like motility issues, maybe a simple stricture, or even something outside the esophagus pushing on it. Okay, so we have our top suspect. Now we need to prove it. The examiner is looking for a really clear step-by-step plan, and the goal here is twofold. 1, confirm the diagnosis, and 2, figure out the full extent of the disease. That's staging. Staging is everything because it's what tells us if we have a shot at a cure. My answer here has to be a logical flow. Step 1, always, is the endoscopy. You have to get a camera down there, see the lesion, and get a piece of it. No tissue, no diagnosis. It's that simple. Once we've confirmed it's cancer, then the staging workup kicks into high gear. We start with a CT scan of the chest, abdomen, and pelvis to get the big picture. Has it spread? Lungs, liver? Then we zoom in with an endoscopic ultrasound, or EUS. This is the absolute best test for seeing how deep the tumor has grown into the esophageal wall. Finally, a PET scan acts as a kind of full-body sweep, looking for any sneaky cancer cells that might be hiding where the CT couldn't see them.
All right, so with a full diagnosis and the staging complete, the whole case shifts gears. This next phase is all about taking that mountain of data and creating a solid, multidisciplinary plan to actually treat the patient.
So the examiner gives us the final results: T2N1M0. Let's decode that real quick. T2 means the tumor is into the main muscle layer of the esophagus. N1 means it's spread to at least one nearby lymph node. But the most important piece of that puzzle is the M0. That means no distant metastases, no spread to other organs has been found. And that is the key. It tells us this is locally advanced, but it's still potentially curable.
The classic MDT question. The case has been reviewed by everyone: surgeons, oncologists, radiologists, and the consensus is that surgery is the way to go. So now the examiner wants to know, what are my surgical options? I need to show I know the different operations, and more importantly, which one to use and when.
What's really fascinating here is that the tumor's location basically dictates the entire operation. For our patient with a tumor in the lower third, the workhorse procedure is the Ivor-Lewis oesophageectomy. That involves incisions in both the abdomen and the right side of the chest. Now, if the tumor were higher up, we might think about a McCune, which adds a third incision in the neck. And there's the transhiatal approach, which avoids opening the chest entirely. Great for frail patients, but you don't get as good a look at the lymph nodes. So for this case, the Ivor-Lewis is really the best choice. And just like that, we're heading into the operating room. The examiner is going to want me to walk them through the Ivor-Lewis procedure, step by step. This is where I have to demonstrate I know the anatomy, the key moves, and most importantly, where things can go wrong.
Okay, phase 1 of the operation. This is all done in the abdomen, and the entire goal is to prepare the stomach to become the new esophagus.
It's a job that requires really careful, meticulous dissection.
So the very first thing we do in the abdomen is take a good look around. We're making one last check for any little bits of cancer spread that the scans might have missed. Assuming we're all clear, we start freeing up the stomach, carefully dividing all its attachments. Then we have to control its blood supply, tying off the left gastric vessels. Now comes the cool part. We use a surgical stapler to basically reshape the stomach from a big pouch into a long, narrow tube. We call this the gastric conduit, and it's going to be the patient's new esophagus. And before we close up the abdomen, we place a feeding tube a little further down in the intestine. That's going to be crucial for recovery.
Now, here is the absolute most critical point of the abdominal phase, a classic exam red flag. The blood supply to this new stomach tube. That entire conduit is going to survive on just one artery, the right gastroepiploic. If I injure that artery during the dissection, the conduit dies. The operation is a failure. It is an absolute non-negotiable step that you have to protect that vessel at all costs.
All right, the abdomen is closed. We've repositioned the patient. Now, for part 2, we head into the chest to take out the tumor and hook up our new conduit.
For the thoracic part, we have the patient lying on their left side, and we make an incision on the right side of the chest. The goal here is to remove the entire section of the esophagus that has the tumor, plus a good margin of healthy tissue above and below, and, this is key, all the surrounding lymph nodes. To do that, we have to divide a major vein called the azygos vein. Once the diseased part is out, we gently pull that gastric tube we made up from the abdomen and create the new connection, the anastomosis, sewing the healthy esophagus to the top of our new stomach tube. Finally, we place a couple of chest drains, and the main part of the surgery is done.
You know, this slide shows a different, even more delicate esophageal surgery called a Heller myotomy. For that, we're only cutting the outer muscle layers to relieve a blockage, leaving the inner lining perfectly intact. I'd bring this up to show the examiner that I appreciate the kind of surgical precision that's needed in this part of the body. It shows you're not just a one-trick pony, you have a broader understanding of the field, and that's a great way to score points in an oral exam like this. The operation is done, but the case is far from over. The post-op period and the long-term follow-up are just as critical to a good outcome, and you can bet the examiner is going to test my knowledge on this.
So, right after surgery, the patient can't eat or drink anything by mouth. All of their nutrition is coming through that feeding tube we placed. Because we opened the chest, the biggest risk is lung complications, so we are super aggressive with breathing exercises and getting him to cough. Getting the patient up and walking, preventing blood clots, and making sure their pain is well controlled are the other absolute top priorities in those first few days. This question is key. It tests my understanding that cancer surgery isn't just about the operation itself, it's about a lifetime of care and being vigilant for any signs of recurrence. Well, there's a pretty standard schedule we follow. We see the patient very frequently in the first 2 years. That's when a recurrence is most likely to happen. At every visit, we're asking about symptoms, especially any new trouble swallowing or weight loss. After that initial period, we can space the visits out. Importantly, we don't just do routine scans for the sake of it. We only order them if new symptoms pop up. And throughout all of this, we're constantly keeping an eye on their nutrition, because learning to live with this new anatomy can be a real challenge.
And here it is, the classic final question, designed to boil everything we've discussed down to the one most critical point. And the answer isn't how slick the surgery was or how perfect the post-op care was. The single most important factor, the one thing that will truly predict this patient's future, is the final pathology report, specifically the nodal status. The presence of cancer in the lymph nodes and how many nodes were involved, that will tell us more about this patient's chance of long-term survival than anything else. And that's the final critical point you need to make to nail this case.